Today are oral immunotherapy and anti-IgE immunotherapy. I'll discuss a mechanism and a clinical trial for each. To start off, a little bit of background about peanut allergies. They're present in about 4% of children and 1.5% of adults. And the prevalence is increasing. That's why we're seeing more and more children having peanut allergies. I think 3 times as many children have peanut allergies now, and just in the last 10 years, it's increased by 3 times. Peanut allergies are not usually outgrown. This is in contrast to other types of allergies and food allergies, which we do see outgrown, but peanut allergies are not. As a result, they're challenging for patients and families. Often it requires an entire lifestyle change just to make sure you're avoiding the allergen. They are a type 1 hypersensitivity reaction. This is an overreaction of the immune system. Basically, someone with peanut allergies' body recognizes peanuts as something foreign, sort of as a pathogen, as it would a disease, and attacks it in that way. The type 1 hypersensitivity is mediated by IgE, which is bound to mast cells, basophils, and eosinophils, and I'll discuss more of what that mechanism looks like. So what do the symptoms of allergic reaction look like? Well, they range from mild to moderate to severe. Mild symptoms include sneezing, coughing, urticaria, which is hives, or atopic dermatitis, which is eczema. More moderate symptoms, wheezing, nausea, vomiting, diarrhea, and abdominal pain. Severe symptoms include a swelling of the lips and tongue, tightening of the throat, and difficulty breathing. And in the most serious cases, anaphylaxis, which is a rapid onset of these symptoms, accompanied by perhaps low blood pressure, dizziness, loss of consciousness. And in the most extreme cases, it can lead to the death of the patient if the symptoms are left untreated or if they're not treated in a timely manner. So what does the mechanism of allergic reaction look like in a type 1 hypersensitivity? The first step is sensitization. A person with peanut allergies is not born with the allergy. In fact, they actually develop the Ig antibody when they first encounter the peanut allergen. So here's our person eating peanuts. So the antigen-presenting cell, usually a dendritic cell, pictured here is a macrophage, but it's usually a dendritic cell in this case, will phagocytose the allergen and process it and present it to T cells on its MHC2. The T cell will become activated and become a Th2 cell. It will secrete IL-4, IL-5, and IL-13. IL-4 will bind to the B cells and activate them, cause them to proliferate and become plasma cells. These plasma cells will then produce IgE, which is specific to the peanut allergen. And this IgE will remain bound to mast cells and basophils. Pictured here is a mast cell, and the IgE antibody binds to the mast cell by means of the Fc-εR1 receptor. This receptor has an alpha chain, a beta chain, and 2 gamma chains. The constant region of the IgE molecule is bound to the extracellular alpha chain. Upon subsequent exposure to the allergen, it becomes cross-linked to the IgE, and a signal pathway proceeds through the beta and gamma chains of the receptor. This activates the mast cell and causes the mast cell to degranulate and release inflammatory mediators. It is then these inflammatory mediators that cause the symptoms that we recognize as a part of the allergic reaction. So specifically, histamine will bind to its receptors on smooth muscle cells, allowing them to contract. This causes the constricting of the airways and the difficulty breathing that we recognize. The mucosa is stimulated to secrete mucus, causing vomiting, diarrhea, even a runny nose. Histamine will bind to endothelial cells and cause vasodilation, increase vascular permeability, resulting in the inflammation and possibly low blood pressure from the vasodilation. TNF-alpha and other cytokines enhance this inflammatory process. And leukotrienes are actually involved in the late stage of the allergic response. They will be processed and contribute to inflammation later on in the reaction. So keep this picture in mind here as we proceed to discuss the therapies. It is this bond between IgE and its Fc-εR1 receptor that's going to be the target of the therapy. So if we can prevent this interaction, we can prevent the reaction from occurring. So what is currently available for people with peanut allergies? Unfortunately, strict avoidance of the peanut is the only current treatment option. If reaction does occur, we do know how to treat the symptoms. So that includes antihistamine, so Benadryl, or EpiPen, which is an auto-injector, and that administers epinephrine. Antihistamine and epinephrine will reverse the inflammatory effects of the inflammatory mediators. So antihistamine will bind to the histamine receptors and block them from binding. So we'll see like vasoconstriction, so reverse of vasodilation, and bronchial dilation and reverse of bronchial constriction. So here's a picture of the EpiPen being administered. And hospitalization is often necessary for people undergoing anaphylaxis. These methods are often ineffective and can be potentially fatal. Ineffective because strict avoidance is becoming harder and harder as the peanut product becomes more prevalent and more contamination takes place with peanuts. Potentially fatal because oftentimes people don't know how to treat the reaction and it goes untreated. So this illustrates the need, because we see the severity of the reaction and how ineffective the treatments can be, this illustrates the need for new preventative treatment options that will prevent the reaction from occurring in the first place. The two treatment options I will discuss today, they're still in clinical trials for peanut allergies, but I'll discuss through those clinical trials and talk about what the potential advantages could be. The first one is oral immunotherapy. It's abbreviated OIT. It's a desensitization by administration of increasing amounts of allergen until a higher tolerance is achieved. There's a lot of different protocols out there, but generally they'll start at a very low dose of peanut allergen and increase until a greater tolerance is achieved. And this has been successful in other types of allergies, particularly environmental allergies. So the next step would be to try it and see how it works for peanut allergies. The second therapy I'll be discussing is anti-IgE immunotherapy. This is an IgG that we manufacture with IgE as its epitope. So it essentially binds to IgE and prevents the interaction with the receptor. Xolair is a drug that's currently being used, and it uses this anti-IgE mechanism. And it's currently used clinically for asthma, which is also a type 1 hypersensitivity. So let's look at the mechanism of how oral immunotherapy works. The top portion of this picture here represents the pathway that I discussed earlier, so the sensitization process. The allergen is first encountered, so here's a dendritic cell that will process this antigen on its MHC2, present it to the T cell. This helper T cell will become activated and differentiate and become a Th2 cell. Th2 cells secrete the cytokines interleukin 4, 5, and 13, which will stimulate B cells to differentiate into plasma cells and secrete the peanut-specific IgE, will be bound to the mast cells. Upon subsequent exposure to the allergen, mast cell will be activated and release its inflammatory mediators. However, in desensitization patients, what we observe, however, is a deviation from this pathway towards the Th1 cell pathway. So instead of becoming a Th2 cell, this Th cell will become a Th1 cell. It will secrete the cytokines interferon gamma and interleukin 2, and this B cell will be stimulated to secrete IgG1 or 4 instead of IgE. The advantage here is that the IgG is still peanut specific, so it can still bind to the allergen and neutralize it without being bound. It doesn't have the constant region to be bound to the mast cell, so it can't elicit the allergic response. So as we discuss the clinical trial, keep these specific cytokines in mind. We'll see a decrease in these cytokines and an increase in IgG. So keep that in mind. We'll see a deviation to this pathway. So Varshney and his colleagues tested oral immunotherapy in the first randomized double-blind placebo-controlled study for peanut allergies. Placebo-controlled just means that this was the first study where they had both an experimental group and a placebo group that wasn't receiving treatment for comparison. And double-blind means that both the people receiving treatment and those administering treatment didn't know who was receiving treatment and who was receiving placebo. They hypothesized that subjects receiving the oral immunotherapy will be able to ingest more peanut than subjects receiving placebo. 25 children between the ages of 1 and 16 completed this trial. They had to have a history of reaction to peanut within 60 minutes of ingestion. Important thing to note about this trial is that they did exclude patients with history of severe anaphylaxis, which is an important thing to note. 16 patients received OIT and 9 received placebo. This was assigned randomly in a 2-to-1 ratio. Peanut flour was used for the OIT group, and toasted oat flour was used for the placebo group, and the doses were administered in the subject's food vehicle of choosing. For their OIT protocol, they began with an initial day escalation phase. Just to give you an idea here, a perspective, about 250 milligrams of peanut flour is equal to 1 peanut. So they began with 0.1 milligrams of peanut flour or placebo. The dose was doubled every 30 minutes until either symptoms developed or 6 milligrams was reached. Next, they proceeded to the home dosing and build-up phase. So in this phase, the doses were ingested daily at home by the subjects. The highest tolerated dose at the initial day escalation phase was used as the starting dose. And the subjects would return every 2 weeks for approximately 44 weeks for dose escalation. The doses were increased by 50 to 100% until 75 milligrams was reached, and then 25 to 33% until 4,000 milligrams was reached. In the maintenance phase, the subjects ingested this 4,000 milligram dose for a total of 1 month. So for keeping track, this treatment was over the course of about 54 weeks, so a little over a year. At the end, they conducted a final oral food challenge, where peanut flour or oat flour was given in increasing doses every 10 to 20 minutes, up to 5,000 milligrams, and the oral food challenge was terminated when symptoms developed, and they recorded how much each patient could tolerate. Peanut-specific IgE, IgG, and IgG4 serum levels were measured, and lymphocytes were cultured with peanut protein for 72 hours to test for the production of cytokines, specifically IL-5, IL-13, IL-10, interferon gamma, and TGF-beta is what they looked for. Here are the results of the oral food challenge. So here this shows the amount of peanut protein that could be tolerated. As you can observe, all OIT subjects, so all 16 of them, were able to ingest the maximum cumulative dose of 5,000 milligrams, which is equivalent to approximately 20 peanuts. Placebo subjects, so 9 of them, ingested a median dose of only 280 milligrams, so approximately 1 peanut. This data suggests significance with a p-value of less than 0.001. This p-value means that there's only a 0.1% chance that this data was due to chance and not to the treatment. Now we'll look at what was going on with the peanut-specific IgE and IgG4. Let me explain a little bit of this chart. This is a box and whisker plot. So here, this represents the minimum, this represents the maximum, so this is the range of IgG levels. And the bottom portion of the box represents the 25th quartile, and the top represents the 75th quartile. And this black line represents the median. As we observe the results, it's helpful to observe the trends in the median and compare that to the placebo. So as you can see, all OIT subjects had a significant increase in IgG levels at all time. This p-value was less than 0.5, so just look at the median values and you can see that this is increasing. OIT subjects also had increases in IgG4 from baseline as well, so again compared to the placebo in both cases, and you can see this p-value was less than 0.001. And there was no significant changes in the IgE levels. Just to know. Here are the results for the secreted cytokines. Again, we have the box and whisker plots. So here comparing the peanut OIT group to the placebo group for IL-5 and IL-13. They both decreased significantly from baseline by 9 months and at time of oral food challenge. So tested at 9 months in oral food challenge. P-values were less than 0.02 and less than 0.03 respectively. So overall we saw a decrease in IL-5 and IL-13. And no other cytokines were observed to change significantly. So in conclusion here, we see that after 1 year of treatment, the subjects receiving peanut OIT were able to ingest a greater amount of peanut than those receiving placebo. The proper immunologic changes also accompanied this success. So we saw the increase in IgG and IgG4 levels. If you recall the figure I showed earlier, we see that deviation to the Th1 pathway. We also saw the decrease in the Th2 cytokine production, confirming that. So overall, we saw that the results demonstrate that peanut OIT does induce desensitization and concurrent immune modulation. While this study did have its limitations, it was a small sample size, they didn't have an initial oral food challenge for comparison, and they did exclude patients with severe anaphylaxis, it did have its advantages in the promising treatment that it shows. And even more interestingly, the study does plan to continue and see what is the long-term tolerance provided by this treatment in these patients. So I think it'll be interesting to see what the results of that study will be in the future.